Good afternoon and welcome to our Nursing Times webinar on using technology to improve the patient pathway, which is supported by an educational grant from Mölnlycke Wound Support app. My name is Steve Ford and I'm the editor of Nursing Times. Today we're going to be exploring the role of technology in improving wound assessment and management. We're going to be covering themes including using technology to improve the pathway, exploring the potential of wound assessment apps in clinical settings, and strategies to overcome resistance to the use of technology and the best ways to implement change. The layout of the webinar will be as follows. We've got two presentations that will last around half an hour in total, followed by a question and answer panel session of around the same time. We encourage audience participation, of course, so please contribute any questions that you have via Teams and I'll put them to the panel. So, if we're all ready, I'm delighted to welcome the first presentation, which is on current problems with wound assessment and documentation. And our presenter is Michael Watson, who is Digital Data and Information Program Manager with the National Wound Care Strategy Program. So over to you, Michael.
Thank you, Steve. And hello, everybody. Thanks for inviting me and the Wound Care Strategy Programme onto the webinar. We're delighted to be here. There's a couple of other panelists on here, so we'll hear later from Jackie and from Anne Jacqueline, both of whom are part of our small programme team. Just to reiterate, as Steve has said, I'm Mike Watson. I'm the Digital and Data Information Programme Manager from the National Wound Care Strategy Programme. I'm part of that small team. And today I'm going to give you a little bit of background on the programme so you can understand why we're doing it, a bit on the how we see data and what this means for wound assessment and documentation systems, so a perspective on how we see things from a national perspective. I should start out by saying as well, just a big caveat, I'm not a nurse or a clinician by any stretch, but I am someone who's feeling very privileged to work on this programme and the outcomes we're trying to achieve. Next slide, please. What I wanted to do was just give you a sense about the sort of the why are we trying to do the work that we're doing, and our programme director, Dr. Adley, would do these points much better than I would, but I'll try and do justice to them. Our work is grounded in the experience of the nurses, some of whom will be on the call today, but predominantly by the research carried out by Julian Guest and colleagues that revealed the huge burden that there is that's posed by wounds in the UK and the costs of the care that's delivered to them. So we can see there's some fairly eye-watering numbers there in terms of the costs, but also the burden that those wounds are placing on patients. This provides us with a huge opportunity to make a difference. So if we can improve the outcomes for those people, we can also introduce efficiencies into how those services are delivered and try and gain those efficiencies across the whole wound care pathway. Next slide, please. I just wanted to sort of draw some attention to that burden, really. So you'll see here that there's the prevalence of the different wound types that take place across the UK, and also the associated costs and the cost opportunities that are there with them. So you can see that there's a huge burden, but also that there's a large amount of cost being spent on managing these wounds. So again, we want to make sure that we can try and find efficiencies and help deliver wound care and management in a way that improves outcomes for patients, but also helps us try and achieve those efficiencies. Next slide, please. So why is that the case? Why is there such a huge burden? Why is there a large amount of effort and energy going into dealing with them? Fundamentally, while we know that there'll be variation in how individual patients are being managed, we do know that there's a variation across the country in how care is organised and delivered to support those patients. So we think that's through the underuse of evidence-based care, but also in the overuse of ineffective interventions. And all this is done, I think, whilst it's known what good looks like, really. So nurses and TVNs will know what good care looks like. So what we're trying to do is encourage a system-level change so that good wound care can be delivered across entire systems, and that everybody knows what to do in that. So we know through the work that Julian Guest has done that there's an absence of data. So we know that there's a lack of good quality data that helps us understand where good wound care is taking place and where improvements could be made. And we know as well that that's predominantly done, partly driven, I'd say, by a lack of investment in community health care systems, and also the digital infrastructure that supports them. So those data and information systems that help us collect good quality data and information so that we can inform quality improvement. Next slide, please. So very quickly, what we've done as a program is produce recommendations. So for example, for lower limb wounds, we've produced recommendations that help describe what we think the optimal pathway would be for people with lower limb wounds. Predominantly, this is about setting out a pathway that describes getting assessment done quickly, getting those patients into compression, and then making a good decision on what the next onward care would be, whether that be into referral, into vascular services, or keeping them in compression and managing their treatment so that they have a better outcome overall. Next slide, please. On the back of those recommendations, what we've also developed is an implementation case, so something that helps to describe in a business case way what those recommendations will achieve. So what those patient outcomes will be, what those productivity gains will be, and what we think the core enablers will be to help you try and achieve those gains. So as I've described, there's recommendations on how that model of care can be organised, what the role of supporting clinicians is in making sure that that care is delivered consistently, so providing evidence-based care and education for clinicians to deliver that care. But really today's about that data and information segment, so making sure that we understand the role of data and the role of information in improving care, and turning data into actionable and usable evidence and insight for managing care on a sustained basis. Next slide, please. So what does all that look like really? So what we're trying to do is fundamentally we're setting out an improvement approach. So something that is continually and in a sustained way, taking data, looking at it, making sure that improvements can be observed and spotted, that those improvements can be put into operational practice and clinical delivery, which in turn generates more data that helps us inform what the next step of improvement will be. And we know that there's a lot of data out there, or could potentially be out there, in terms of how the pathway is being delivered, what products are being used along that pathway, how education is being taken up, and then what staff models are being used to deliver that care. So if we can create a sort of virtuous cycle of collecting data, using it to think about how services are delivered, and then using that data again to continually improve. So fundamentally, we are a improvement program, but that's trying to introduce an improvement methodology on an ongoing basis. Next slide, please. So going a bit further, what do we mean within that? So within our implementation case, we've set out the need to establish, the need to collect and analyse high quality data, if we can, along that pathway to both drive and deliver improvement. The implementation case sets out two things really. One is to create that information feedback system that I've just described in the earlier slide, that helps inform both clinical needs, so the delivery of clinical care to patients, but also that can be aggregated up to inform business needs as well. But in order to do that, we know that we need technology at the point of care to do that. So we describe the rollout and use of NHS mobile digital technology that can help support clinicians capture that data, and I'll go into a bit more detail in that in my later slides. Next slide, please. So how do we as a national programme see this data being used? So we know that there are probably three or four, it's three on this slide, there's probably another one as well, 3 or 4 big key areas of data that could be used to inform how wound care services can be organised and delivered. We know there's lots of information about the patient that's available or could be available. There's lots of information around what staff are being used to help deliver that care and how productive they can be in terms of the different models that could be delivered. Lots of information about what products are being used, so that whether that be wound products or equipment that's being used to deliver care. And we're also thinking now about what the patient experience will be as well. So can we sort of ingest data and information about the patient experience? And what we want to try and do is do that in a way that both, as I said, informs both the clinical care, so helping clinicians make informed decisions at the point of care, but also help them do audit and understand that improvement that they can do locally. And then what we'd like that data to do is also then be aggregated up so that it can help inform things like commissioning and the delivery of those services, and then onward business cases as well. So can we collect data in a way that helps meet both those needs? Next slide, please. And I started to allude to it in my last slide, but what we're trying to say as well is that we want data to be captured at the point of care, but that can be aggregated up to meet different levels of need, both clinical and business. So what we see is data both working across the pathway, but also being aggregated up so that it can inform what a local provider is doing and how their services are performing. Then that can be built up as well to the next level, which is if we combine data about local providers, what does that mean for an ICS footprint? So can we go up another level and see where there's opportunity to commission services on a broader footprint or make changes across an ICS? And then aggregate that up even further and say, well, can we then start to understand what wound care services are and how wound care services are being delivered either regionally or nationally, so that we can spot those variations that Julian Guest found in his work that I referenced a bit earlier. Next slide, please. So what does that mean? We've arrived therefore at sort of two core data principles. So if you can imagine all this data that's sitting on one side, what we really are recommending in our work is that data collection is done at the point of care, but those business needs are secondary to operational practice. So information and data does need to be collected, but that needs to be the business needs need to be derived from operational and clinical practice. It's not another data set that we want to collect on top of it. What we also know as well is that we want not just any data, we want good, high quality data. So, and by that I mean it's complete and it's consistent, it's accurate. So what we know is that given that lack of investment or patchiness of investment in community care, is that the data that we have today isn't necessarily always going to be good quality data, but we'll only know where the gaps are in that data if we start to use it. So by using the data that we've got and looking at it and seeing where the gaps are, we can build in the improvement that we'd like to see into where data could be improved. So again, you can see our sort of improvement methodology flowing through just not how we work as a program, but integral into the sort of the way that we're thinking about some of the things that we need. We're thinking if we can do this consistently across wound care services, we'll be able to see where the opportunities are to improve wound care management and services for everybody across the country. Next slide, please. So as a national program, what have we done so far? So we've done some work that tries to understand what point of care digital systems exist out there in the market today that could support people to start doing this. So this isn't a list of everything, it's just those that we're aware of. So this register of known wound management digital systems, which is the phrase we're using for that point of care digital technology. So we've got a register there that people would go to and see what technology options are already available out there. What we've then done as well is done quite a lot of engagement. So it's quite a large exercise to engage with both the market and clinicians and service managers to understand what would a good wound management digital system need to be able to do. And I'll come on to that a bit later, but we've described this thing called a functional overview, and it sets out those capabilities and functionality that we think a wound management digital system needs to have in order for us to achieve our aims as a national program, again, to meet those lower limb recommendations and the points that we've made in the implementation case. And then what we've also started to do then is build on that work to think about how can we describe what an information standard for wound care would be as well. So if we understand what digital systems exist, what digital systems could look like and may already look like, can we now start to put some shape and some structure around how information and data should be collected, either in the record, but also how we can make that interoperable across that pathway as well. So can we start to describe in a standardized way how data can be shared across that pathway to deliver the recommendations that we've got? And we've also developed some advice and guidance as well around using digital imaging, for example, to take good quality data as well. We see the image as being part of the data set for wound care, not the only thing, but definitely a core part of it. Next slide, please. So in summary, what we're describing that functional overview, and I think partly what this presentation and this webinar today is around is what do we think we mean by this functional overview? So what do we think a good wound management digital system needs to be able to do in order to get that good high quality data and documentation that's driven out of that assessment process? And you can see here what we've done is we've sort of tried to describe some fairly big broad capabilities and then broken that down further. So in our view, starting with this idea that we need to be able to capture data at the point of care, is that we want to make sure that we're providing that functional layer of clinical support and linking information and patient data, so that as a clinician somebody can see exactly what's going on with a patient, but also understand what patients they might have in that cohort as well. So they can start to understand, sorry, in that cohort, in a group of patients, how can I best manage the group? You know, how are people healing? How is that group of patients that I'm managing progressing? So you can start to identify where you might do more work over here and less work over there. So if we're capturing that data at a functional layer, what we want to be able to do is make sure then we can do some measurement as well. So can we provide a view to people about how, you know, where staff are working, how they're working, what products are being used, then making sure that data then starts to importantly move over into the big national returns. So we know that we need to submit data to things like the community services data set. So we need that, both the measurement to take place locally, but also to push data out through to the national returns. All that's based on a long-term record of the patient, and that record needs to both be around that episode of care that you might be giving in wound management, but also linked to other care plans that patient might be under as well at any one moment in time. So we need that interoperable layer to link between people. And all that's built on a solid foundation, all the stuff that you would expect a digital technology to have in the NHS today. It needs to be secure, so we need to make sure the right people are using it, the right people can access the right data within it, and that those accesses can be controlled at a network level as well. And then fundamentally that all of that needs to be done in an integrated way. So we need data to be able to move across the pathway of that patient as they move across any particular pathway. So we need that interoperability, and that interoperability will be fundamentally linked to that NHS number, the one identifier that a patient can have. So what we've tried to do here is summarise what we think a good digital solution would be to help achieve those aims of good wound documentation and good wound assessment that meets those needs that for both the patient, the clinician, but also then provides that broader digital and data, that broader data view that we need to make sure that wound care services are being managed in the best possible way for both clinicians and for patients. I hope that helps, Steve. Thank you.
Fantastic, thank you, Mike. Some really interesting insight there on the importance of data and how we use it. Very interested to hear about the information standard for wound care there as well. Very interesting. So on to our next presentation, our second presentation of the day. So this one is on using technology to improve wound assessment and management. It's presented by Jeanette Milne, who is Chief Matron for Community at Northumbria Healthcare NHS Foundation Trust. Over to you, Jeanette.
Thanks, Steve. Next slide, please, Melissa. So I guess our first speaker talked a lot around the current and medium and long-term plans for data and innovation, but I think everybody on the call today has probably worked through seeing the NHS respond at pace in relation to making changes to the way we collect data and the way we manage patients. And I was involved in a programme of work in terms of the NHS Futures around what changes happened during the pandemic, and I want to speak to you a little bit about this today. So I think within the National Wound Care Strategy programme, there was also elements of increased self-care during the pandemic, and I think we wanted to understand what innovations had been seen during the period, what were the impact of the innovations, and how people were using not just data but other forms of technology to impact service delivery, and what what the respondents also wanted to do in the longer term in terms of that service delivery, because I think you'll agree, and I definitely agree with Michael in what he said in relation to interoperability as an integrated service in Northumbria. We have lots of different systems in terms of, we have our acute-based electronic patient record, we have System 1, we have some GPs using EMIS, and I think that agnostic nature of whatever apps and things that we put in place that enables a readback function into whatever record is critical going forward. And I think there was an awful lot of different systems popped up during the pandemic as well. Next slide, please. So the summary of the results from this survey were that 314 responses were received. The highest response was from the Midlands area, but you can see that the majority of respondents worked in community trusts, and there was a limited number of responses from mental health and primary care. But essentially, most respondents were nurses at 78%, and 56% were employed as tissue viability nurses. And there were a range of roles, though, that were represented in the sample. Next slide, Melissa. So I think the main changes and themes around innovations were about the increased use of remote consultation and video conferencing and digital image transfer during the pandemic. A number of different systems being used to focus that. Obviously, a lot of NHS trusts scaled out things like Teams and AccuRx from a primary care perspective at a huge pace, and we as a trust also used a form called Attend Anywhere. Pre-pandemic, we as a tissue viability service in Northumbria were using Visiba Cares as a way of facilitating remote consultations, and I'll speak to that a little bit later on. But in terms of taking those digital images, I'm sure you'll all agree that no nurse really entered nursing to be a digital photographer, and the quality of some of those images can be quite challenging. And I think in terms of taking those, it's always very difficult, sometimes if it's patients, to always access that body surface area. So it's really important to be able to get multiple people onto calls, and I think consent for sharing and all of those things are critical here. But there were a whole host of digital apps that also helped to support staff accessing clinical information when working remotely, but also a whole host of services that were provided by our commercial partners as well. And delivery of education was very much via e-learning, and I think that had advantages because it opened up education to a wider audience than perhaps would have been able to access previously. Melissa, can I have the next slide, please? In terms of the impact, there was very much, from a specialist perspective, a feeling that there was an ability to spend more time reviewing patients with more complex wounds, and this was because it freed up the time and digital images were being used, say, to triage patients into the right care pathway quite quickly, in terms of whether somebody was kind of worried well with a wound or had more significant problems that needed to be seen by somebody with more skills within the team. I think there was a feeling that virtual pathways and data enabled people to support care homes more effectively, and that was also reduced the carbon footprint in terms of travel. In Northumbria, for example, we have a 550 square mile radius that we cover, but also it helped the care homes from a reducing footfall and reducing that risk to vulnerable residents from a COVID transmission perspective. But it was felt that those patients were able to be cared for in a timely and efficient way that mitigated their risk. And I think it was well received by clinicians generally, and there was a quicker review and instigation of treatment. Next slide, please. I think in terms of impact too, I think generally the programme, both nationally and locally, has very much been about self-care. And I think these are some comments that were provided by respondents to the survey, but in relation to that, I think it was felt that the door very much opened by the pandemic, and patients were saying, you know, I'm willing to self-care, because there was a fear element associated with people coming into their homes. But equally, the virtual consultation allowed patients to still have access to clinicians, and especially the service that we were using, it allowed both drop-in sessions where patients can make their own appointment and the staff would attend that. And a bit of a kind of section where the patients could then put information on about why they were wanting that contact, and they can upload images and things prior to that contact. So again, the clinician didn't feel that they were on the back foot in relation to providing the right advice to the patient, and they could retrieve the patient's records and see prior to that consultation what had been done before. Some services said that there was support for prescriptions issued by tissue viability. That concerns me somewhat in terms of taking GPs out of that, but I think it has merit in some respects. However, if you look at most tissue viability services, we are a very small service in compared to, say, the number of district nurses that might be out there. But equally, you would need prescribers at all levels around there. But patients were generally responsive, and I think I'll talk a little bit about risks a little bit later on. Next slide, please. I think in terms of productivity, lots of respondents talked about more robust referral pathways, but more speedy ones as well, which reduced the number and the need for the amount of information and data transfer that were quicker for clinicians to use, as opposed to really wieldy kind of referral documents and things that were prior to being used prior to the pandemic. And in terms of the patients and staff reviewing, it was really good to see that patients were able to access video consultation, but also could hook in other staff members as well from a multidisciplinary team perspective. So it wasn't just with one member of the MDT. And there was a shift towards more general staff undertaking aspects of wound care as well. And I think I'll talk to that a little bit later as well on a future slide. Next slide, Melissa. I think there was generally a greater collaboration across multi-professional groups and organisations. For example, we have a regional burn care centre, but when patients were able to receive local point of care for their burn, but also hook in with the regional centres as well. But equally, in terms of vascular, we don't have local vascular services, but it increased our ability to access that tertiary vascular review of patients. And I think there was a desire overall to retain these changes and retain the ability to speak across organisation as well as within organisation, and link in primary care as well, with secondary care generally. I think there was increased autonomy for non-specialist staff, and by that I mean in terms of other staff groups using these care models, and really there was a very much openness to staff being able and willing to try new things and report back on what the outcomes of those were. There was a huge support from the National Wound Care Strategy Programme to increase the number of documents available, both in terms of digital photography, but also in terms of resources for patients and clinicians to support self-care for patients as well. So I think there was very much a view towards getting people into the right care pathway, getting the right treatment initiated, and then making sure that people were supported to carry out that in practice. Next slide, please. there was generally a feeling that roles expanded, and I think this kind of ties in nicely to both the Getting It Right First Time programme, but also in relation to making every contact count across the services. You know, so if in our local area, for example, and I'll talk a little bit more about it, but our podiatry services work much more closely with community nursing, and they would perhaps do compression in the height of pandemic, and so they weren't going in with a nurse and a podiatrist when the podiatrist wanted to review the foot wound. They could then do that as well as part of their care pathway. And I think that improved patient experience, but also increased productivity across the system. Next slide, please. I think in terms of risks, there were some local services suspended, and you know, I don't want to spend too much time talking about that today, but I think there were risks across the system. Some, for example, tissue viability services were stood down. We didn't actually do that in our area. We actually embraced technology to try and help us increase the availability of resource across the area and reduce footfall in patient homes. And obviously COVID transmission in care homes ceased visitors, and I think, you know, with regards to safeguarding and things, we will see whether that had any long-term effects as kind of way we look back over into those issues that may have occurred locally. But I can only talk about our experience, and it was a very positive one. Next slide, please, Melissa. I think there was a feeling that some people with lower limb wounds and ulcers stayed away, if you like, and didn't contact anybody, and perhaps contacted people later and had more complex wounds before the point of first contact. And this was fear from patients, because a lot of patients with lower limb wounds tend to be in the older age categories, and those patients themselves often were the vulnerable patients. But I think in terms of being able to allow access to different apps and technologies allowed people to have that access to professionals. But again, until we look back and review some of the things that did happen, we won't know fully the impact of that and be able to apply those lessons looking forward into the strategy. And I know that is definitely something that Una and Jackie and the others responsible. And I think in terms of also making sure, as Michael said, that the codes and things that we are putting against these activities are all compatible with all systems will make it really much more robust going forwards, perhaps, than we had at the time. Next slide, Melissa. I think in terms of locally, just to sort of further a little bit around what we did, Tissue Viability had very much centralised clinics, and staff and patients were travelling quite a distance to them. So we very much put the services into local areas during the pandemic, and the community nursing capacity was released into communities. So Tissue Viability led with those clinics, and we found that increased both productivity, but it also increased the number of patients that were moving towards self-care, and it allowed Tissue Viability to then remotely monitor those patients and again reduce the number of miles travelled for patients and the carbon footprint of the trust. And I think patients very much felt very keen to do that. And I think in terms of using video or telephone consultations, what we found through our audits were that patients want choice. That it's not that they don't like the use of video technology or telephone consultations, but if they want to be seen face to face, they want to be able to instigate that and have a choice. We've continued to align our tissue viability teams from a community perspective to every primary care network, and they work now embedded within the primary care networks and the community teams. And longer term, we're embedding local clinics to go alongside that, so we can upskill the nursing staff and improve the outcomes for our patients. Next slide, please, Melissa. I talked a little bit about podiatry redeployment, and I think, you know, podiatry, physio and other teams very much link very closely in, and I think we need to think about more our AHP family when we're looking at wound care as a whole. And, you know, this quote here from staff, I think just feeling that there was a very different viewpoint. The podiatrist assessed the patient from the feet up, whereas the nurse started the assessment at the top and worked down and they met somewhere in the middle. And I think for me, it is about that different view of those clinicians, but also bringing together skills and again, making every contact count. So we've got the least amount of people with the right skills in the patient's house that can do a full assessment of those patients. Next slide, Melissa. I think in terms of virtual care provided by the MDT, there was real strong links seem to emerge, and I think you know, one highlighted example was really quick review of a patient that was highlighted concerns by a social worker of a young client who had been buying dressings, where we were able to get a diabetic nurse, tissue viability nurse, podiatrist, diabetologist and district nurse within 24 hours on a Teams call, whereas trying to create and bring people to a non-virtual setting would have been very difficult prior to that. And being able to share additional information using apps and safe digital transfer of images was really critical to that. And I think, you know, in our area, and I'm sure some of yours, geography just challenged the services. And, you know, previously we had people travelling half a day just to see one patient, which is clearly necessary if that there is a clinical need. But if the tissue viability nurse can see people virtually, they can obviously see many more patients if they're not traveling in a car to those appointments. Next slide, please. I think in terms of the pre-pandemic, I just want to highlight, I have written up our experiences of using Visiba Care. In terms of risks, we still have digital exclusion areas in terms of black spots to our community. For example, we've just had Storm Arwen, and that has impacted significantly, and we need to think about contingencies in around our vulnerable communities with that. But I have published this paper in Journal of Wound Care if people want to talk about digital consultation that goes through synchronous, asynchronous, drop-in clinics, and perhaps the features and advantages and benefits of just general virtual consultation. And we're looking at using Accurex more widely going forward, because that links in with the clinical record. But essentially, I think I would encourage everybody to look to this and the National Strategy Programme to really put the foundations in with regards to that agnostic read back. Next slide, Melissa. I think we have locally a community nursing strategy, and you can see here technology is front and centre of the middle of that key objectives for that. And I would encourage everybody to look to your strategies within your organisation and link any business cases and things to the local strategies to support strategic aims, and data collection and metrics is central to that as well. I feel very strongly that data should work for people, and we shouldn't have people duplicate entry or manually trying to pull data in 2021 and going forward. So I think it's just to put that on everybody's radar, really, that should link in. And I'm quite heartened that this strategy also links in with Sam Sherrington's recent community nursing strategy as well. Next slide, please. So I think, you know, just to point out that there is that National Community Nursing Strategy Plan, and obviously the action areas are around driving the use of digital and data, and I think that is very much the focus of today's session. And I would like to thank the Nursing Times and it being sponsored by Mölnlycke for asking me to present today. And I'm happy to take any questions.
Great, thank you, Jeanette. Fascinating piece of work there. I was particularly jumped out at me the bit around choice, actually, and also sustainability as well, which is obviously something that not everyone thinks about, but really interesting. So as promised, we now have time for our Q&A. We've got around 20 minutes, so please send any questions you have for our panel via Teams using the Q&A button, and I'll ask them on your behalf. If there's a question directed at a particular panel member, please flag that. That'll be great help. So as well as Michael and Jeanette, I'm delighted to say that we're being joined by some other panel members. We've got Mike's colleague, Anne Jacqueline, who is Digital Data and Information Programme Lead at the National Wound Care Strategy Programme. We are lucky also to have Jackie Fletcher, OBE, who is Senior Clinical Advisor, NHS England and Improvement. And last but not least, we have Rebecca George, who is Community Sister and Practice and Professional Development Nurse at Carmarthenshire Community, which is part of Hywel University Health Board. So yeah, get those questions coming in. So I'm going to kick off, if that's all right. Jackie, I'm going to come to you first, just because you've got a particular national perspective. Just looking overall where we are with the use of technology and improving the patient pathway in nursing, especially when it comes to wound care. Do you think we are we where we should be, or how far along the pathway are we, in your view?
I think it's very variable, Steve, and I think it depends on the commitment from your organisation. So some organisations are much more geared in and clued in than others. So what we see are organisations like the one Jeanette works in, where you can see it's absolutely front and centre in their work, but other organisations less so. And I think the best example I can give you of that is maybe a little bit dated, but if you think back to a couple of years ago, just slightly pre-COVID, when we had that horrendous Friday when all the NHS systems crashed and nobody had email. And what was really apparent was that some organisations had invested much more in their technology than others and were able to recover very quickly, whereas those with much older technology had significant problems. And I think that, you know, that's the same across the piece. So we do have organisations, and some of our first implemented sites are key examples of this, where they are very engaged with technology, they're leading the ways, they've been evaluating things, and they're already producing really robust data to support clinical choice and to support what happens for patients, but others who are very, very far behind.
Great, thank you. Yeah, that makes sense. So variation, recognising that it needs investment. Yeah. Okay, so moving on to Rebecca, if I may. I know you've got some really practical experience of technology at the local level. Would you mind sharing with us what you've been doing and how it's been going, please?
Yes, no problem, and thank you for inviting me. So just really want to touch back upon what Jackie's just said, really, from that from a digital point of view, it is very variable. So I work within a rural health board in Wales, so I do think we are quite behind, and all of our digital initiatives seem to be pushed from an all Wales government point of view, so it depends what their priorities are at the time to see where their investments are going. But from a very local point of view, from Carmarthenshire, where I work, I came into post mid-pandemic, September last year. From a wound care point of view, recognised as a district sister that we had not had any training, standardised training or education provided for our district nurses for a very long time. So hands forced really through the pandemic, had to think of a way of delivering some standardised education and training for all the nurses and make that accessible. So I had a really quick crash course on delivering education, bringing in key stakeholders to deliver with me through Teams initially. And we did that for the first probably 6 months of my post. There was obviously a lot of resistance to begin with. It took a lot of time and effort and, you know, patience to get people to engage, really. Then we moved on to a bit more of a blended approach, using technology to get information and education out to the masses, and then bringing it back into local teams, then a bit more of a face-to-face to just reiterate the messages and just to make sure that we had a consistent approach across the county, really. So very much on a small scale, but starting.
Yeah, fantastic, thank you. I think that's really valuable. So we've had a question in. It refers, I think, to something, a point that Jeanette made around images. The question is, what are the recognised digital solutions to take digital images of pressure ulcers or wounds, or are there any? Don't know. Is that one you know about, Jeanette, or is that?
So I think in response, there is the document that Michael referred to in terms of taking digital images. Locally, what we did was made sure we hooked in with our IG departments, and where possible, we've made sure that our systems take that image within the patient record, so it puts it in the right patient record at the point of taking the image, so it averts the need to send that on anywhere else. So we've been led by IG. We're using the systems that the nurses carry around anyway, but in terms of limitations to that, it's all about how the nurse takes the image, where from, you know, the different things. But I know Michael can talk to what's happening a little bit more around a national platform, because, you know, we know that 40% reduction within 4 weeks is a good prognostic indicator, so it'd be really great if going forward we had a measurement tool with them, but appreciate that wounds are very much three-dimensional and you can't often see on the surface the extent of the wound as well. So I think we're on a journey with that from my perspective.
Great, thank you. Do you want to add to that, Michael?
Yeah, thank you, and I'm really pleased that Jeanette, you made that point. I think about, you know, the need to make sure that the image, and again I'll stress the point I made earlier, you know, we sort of see the image as being part of the structured piece of data that needs to go alongside that episode of care for a patient. So it's great to hear that linking back to the patient record's been made. I think all I wanted to add is, you know, in terms of the sort of the recognised digital solutions, and thanks again to Jeanette to signposting to our register of known wound management digital systems. I think sometimes it also comes down to just understanding what the use case is that you want to try and use that image for. So there are those that will do some of those more complex pieces of work for you, you know, and we've got those, I think, on our register, things around measuring and storing that record. I think there are others as well that, you know, just help the transfer of an image from one place to another. So you're not necessarily going to do anything whizzy with the image, but you want to make sure it's being shared to support things like MDT that I think Jeanette talked about a bit earlier. So I think it's, again, if people start to think about what their use case is, then they can match the technology to that, as opposed to being led by the technology, if that makes sense.
Great, thank you. Yeah, lots of questions coming in now. So I've got two. So can't tell you who they're from, but so person says, I wrote my dissertation on the use of technology by nurses in managing the care of patients with type 1 diabetes after working with district nurses in New Zealand who were early adopters of technology. Have you looked at how other countries are using data and digital working? And the second one is, as a trainee nursing associate, what advice would you give to help become more aware of wound care improvements? I think Anne has said she's got a response to at least one of those.
Thank you. Yes, I do, and thank you for inviting me to join the panel. So the second one is the easiest. Go to the National Wound Care Strategy Programme website and sign up to be a stakeholder. So we have an extensive stakeholder arrangement where we send out regular information, and you can get updates on the programme. So that's what I would recommend that you do. Keep an eye on Wounds UK, because we're publishing regularly different updates, and of course the Nursing Times, who we will be working with to publish some of our work. With regard, Oliver, and thinking about, was it Oliver that raised the, no, yeah, Oliver, about are we looking internationally? We are aware, we did some horizon scanning when we first started, and each of the wound care digital management systems providers that we're working to, many have a very strong international base. And so it's not just a UK based approach that we're working with. So we are keeping a scanning horizon, and in addition to the practical guidance on digital imaging that Jeanette mentioned, and the functional overview where we define what we mean by wound management digital systems, we also have on our website a register of those providers of wound management digital systems that we're currently aware of, that people can go to as a resource, which shows which companies we're aware of and which sites in the UK they're currently working with. But we do have a broad international base to the providers that we're currently working with.
Great, thank you. I think Jackie wanted to come in on one of those as well. I think the nursing associate question, I think. Oh, you're muted, Jackie, sorry.
If I can answer what's about keeping updated, I think it is really important that you keep track of what's coming ahead with National Wound Care Strategy, but also if that question was much more generic, it is very much about ensuring that you're keeping up to date with your reading. And I appreciate that for everybody, time is always a pressure. But even if you are scanning journals and literature, just seeing what the headline topics are and start to understand what you're interested in, then you can focus very much on particular areas and develop knowledge in that area. I think one of the things to say is it's very difficult to know everything about everything, and certainly as a team we find that in the National Wound Care Strategy. That's why there are a team of us each with separate areas, and make sure you link into your colleagues, talk to your local tissue viability service, follow what things they are doing. Also use social media, and if you follow key accounts like the National Wound Care Strategy account or the Stop the Pressure account, that will keep you up to date with things that are either happening relatively soon or even things that we're looking for help and support on. So social media can sometimes be a good way, as long as you're selective in the accounts you follow, of keeping up to date with things.
Fantastic, thank you, Jackie. Question in from Mark. He says, I work in telehealth in Newham, so that's East London FT, where we have a simple SMS text messaging system that we use to follow the skin bundle to prevent reoccurrence of healed pressure ulcers. And he just wanted to share that with attendees. Now, I think, Jeanette, did you think that was a good idea?
So I think it is a really good idea, and I think and with an ever-aging workforce and an ever-expanding amount of things that the community nursing teams respond to, including COVID vaccines and booster programme, it's really critical that we look at all things that we can do to help patients care for themselves. And I think it would be, as Jackie said, it would be interesting to know what this covers and how it's triggered, for example, going forwards, because I know we are looking at what text messages we can send, in relation to how we send them. And also, I think just tying in research and development in this as well. So we've got some data and we've got some robust feelings about how patients feel about getting these, and how that's evaluated by the end user, because clearly not all end users can respond to text that are at risk of developing a pressure ulcer. And then, we may need to think about other care agencies that we link with as well.
Great, thank you. So yeah, we might have to get some more information from Mark there. Okay, any more questions coming in? Not just yet. Okay, so I'll carry on with some of the ones that I've got. So this is probably one for Mike or Anne, just as that was what they talked about Mike talked about in his presentation, which interested me, which is about the information standard for wound care. Is there any more you can tell us about that at this stage? How close is it to being a thing? Or when can people start using it?
I can pick that up if you like. So yeah, just very. I mean, we've just started. So what we've done is we're engaging with the professional record standards body to help us try and understand what we've done so far and what work, all the work that the program has done so far in terms of its engagement and understanding what the information needs are. We're working with them at the moment to try and do an evaluation really about where we are with what we've got. And that will then inform our forward plan. So it's a piece of work that's very live and very current for us at the moment, but it's something that we're hoping to produce over the next year or two.
Great, thank you. And moving on, again, this could be one for those with the sort of national hats on. Just obviously it's been mentioned, so I think it's probably something that people are interested in, which is of course apps and the fact they're increasingly being used in healthcare. Obviously some have got more potential than others. I suppose, the question is, do they have a positive role in helping nurses with wound care? There's Anne's nodding her head there, so I'm going to go to Anne.
Absolutely. What we're aiming to do is make life easier for nursing staff to release productivity, and particularly to help people to have the evidence base at their fingertips, particularly in community where you're working remotely. And what we know is that the best digital systems, through their design, will take you through the best evidence-based pathway to help you and provide you some clinical decision support about where you go next. So that they absolutely are designed to support nursing staff get the right clinical decision when they have such busy, complex jobs dealing with such multiple morbidity. We also mean that they enable us to have continuity of care by having better access, live access to a previous record and a previous caregiver, as well as for both the nurse and a patient, the real value of seeing progression in wound healing if you've got a digital image. It removes the need from our old paper-based systems, which we still have, of visiting a patient and then driving somewhere to type some information into a record, either in your car or back at base. So we see enormous gains in terms of the way we provide clinical care, the way we can provide review, the way we can prove in speed referral. And the key is getting the user interface so that actually they don't take more time and that they interoperate with systems. But we think there are huge benefits to be had. And we need to work collaboratively with system developers to drive the very best systems that really tackle the needs of community nurses who have very difficult jobs to do and very challenging.
Great, thank you very much, Anne. So I've got another question in from the audience, which is, so I'm not sure who it's from. Anyway, so the person says, moving from a predominantly rural organisation to a city trust with greater diversity of population, I'm keen to understand how information and data will inform best practice and learning that is more inclusive to include darker skin, and that includes imaging being sophisticated enough to address the differences. Is that something that the panel, Anne again, in fact? Great, thank you, Anne.
So there's a couple of things. The programme are very engaged with this, and we're aware of a recent resource that Wounds UK, I think, was a consensus statement on darker skin tone. It's absolutely central to our work, and it's about and it relates a little to my last answer. It's about the practical uses of these apps. We are about to do another set of engagement with the suppliers of wound management digital systems that we're aware of and working in our programme to confirm that their apps are able to deal with a range of skin tones, and we will make that an important part of our functional overview upgrade if we missed it out the first time. It's absolutely essential that any any digital imaging system can cope with a range of skin tones. It's also essential that our guidance that we produce across all skin wound types begin to address this issue, which is really important.
Great, thank you very much. Right, well, that's that time has flown by, and we're pretty much almost out of time. So what I'd like to do now is just go around the panel very quickly and just ask you all to give me a take-home message, just from either what you've heard today or something else that that you think is important. So I'll start with Jackie.
I think for me the key message is that digital is the way we're going to work. I think there've been so many people who've been resistant to technology that we've demonstrated so clearly during COVID the benefits of doing that we have to take that and move forward.
Great, thank you very much. And I'll go to Jeanette next.
I think engagement at all levels in an organisation is key. You know, with all of your stakeholders, if you are going to take something forward, making sure that it meets the needs of the organisation, and also looking at the national programmes as well to see that they keep pace, I suppose, and make sure the interoperability is there of any system that you adopt.
Great, thank you. And maybe Rebecca, could you give us a take-home message?
Well, my message is probably aimed towards the members of the audience that are new or starting out in introducing technology to their clinical practice. And it would just be to embrace it, start small, expect resistance, but be patient and keep chipping away at it, because it will improve standards, it will increase productivity, and it will improve the quality of care.
Great, thank you. Great advice there. Stick at it, chip away. Love it. Mike, your comments.
Thank you, Steve. I think I might just echo what Rebecca's just said. Actually, I think we talk about digital, I think, often as technology, but I think there's also, it's about how you think about how you deliver your services or how you think about doing projects. And I think she's just described, you know, a very neat, agile way of doing it, which is, you know, start small and then use the data that you can get from your small pilot or your small project to inform what you do next. So I think I would just reiterate the idea of that, you know, that start small and use the data and the technology you've got to think about what your next step is going to be.
Great, thank you very much. And last word goes to Anne.
Thank you. And I would sum up what Rachel and the others have said by saying, come to this with your improvement hat on. Because a lot of improvement is about starting small, thinking about the small steps you make and thinking about working in collaboration. We heard a lot from Jeanette about it's in collaboration with your other colleagues, it's in collaboration with your patients, and it's in collaboration with your IT system providers. Start small, but bring your improvement hat so that it's an improvement